So hello again to everyone. So this is really a very difficult topic, and as you have noticed from the program, most of the options that you have when facing a re-rupture have already been addressed by previous speakers in the morning, right now perfectly by Jean Cani. So I'm going to try and make a kind of a wrap-up and also give a different approach to this talk, because in 10 minutes, that's what's possible. So this is a very clever message, I think, from an experienced surgeon, and I believe that it applies perfectly to this topic in a way. All of us, as shoulder surgeons, we've bumped into these kind of situations, re-ruptures of cuff tears, and we must be aware that oftentimes the solution for this is not necessarily addressing the cuff tear itself. We must be aware that there are other conditions that contribute to the failure, to the clinical failure of that specific patient. So we must be able to identify which other conditions may be present and maybe address them instead of addressing the cuff tear itself. Now, evidences around failure of cuff repairs are scarce, and many of them are not that clear. But there are some evidences that we know. The re-tear rate is on average 22%, according to this large meta-analysis, but in fact it can range from 10 to 94%, depending on the series, on the kind of tendons involved, and so on. Another evidence, which is kind of obvious, I would say, the better scores come with those cases where the rotator cuff stays intact. We also know that the healing of large rotator cuff tears is not critical for long-term clinical results, good clinical results, especially in older patients. And we also know that the rotator cuff integrity does not necessarily seem to affect the clinical scores, at least in the short term. And I spoke about that in the morning. Now, when facing a suspicion of a re-tear, and well, you as shoulder surgeons, I would strongly advise you to take the ultrasound, because it's a very, very useful tool in your office. Because if you suspect it, you can, in 1 minute, rule out a re-rupture. So it's a very, very helpful weapon you have available. It avoids time and money-consuming workup with imaging. It also avoids having the patient knowing by some radiologist or some MRI report that your construct is gone. So the patient gains confidence in you, and you can study that rupture furthermore with other imaging. Now, this is a recent review on what's available in the literature, and these authors concluded that only occasionally re-ruptures actually require surgery. So it's not the fact that you have a re-rupture that means that you have to address it. Also, they concluded that they verified that one of the most important factors that contributes to poor results is the fact that that patient may have had a poor preoperative range of motion, besides obviously the quality of the tendon, the fact he's a smoker, and so on. And revision should be considered in those younger patients with a non-cellular paralytic shoulder, where you have intact deltoid, and obviously if you have a repairable lesion. So, surgical options. Again, we have been over that in the past talks, so I'm not going too deeply into these because they were perfectly addressed by the other speakers. You have augmented repairs with scaffolds, but we all know as well that we still don't have enough scientific data to support all of those. Tendon transfers. If you have no arthritis, with loss of external rotation, and as long as you maintain active elevation, preferably. You have the superior capsule reconstruction, again, with in those cases of post-superior rotator cuff tears with no arthritis and loss of elevation. That may be an option, good option. The spacer, we've been over that as well. arguable, as we know, but it's still an option. And then the reverse arthroplasty, which is probably the best option when you have a pseudoparalytic shoulder that was already pseudoparalytic because before the first attempt of repair. In those cases, it's definitely more predictable than trying to redo the repair. But is failure of that rotator cuff the actual problem? Is it addressing that re-rupture the only option? No. You mustn't forget there are other conditions that contribute to that, stiffness, for instance. So if you have stiffness, in case of diabetes, should you address the re-rupture that can eventually be there? No, probably not. Well, address the capsulitis. AC joint arthritis, that's quite common. It may have passed and missed at the first approach. If it's present, try to rule out the importance of that pathology and situation to the clinical unsuccessful result. And if it's the case, maybe there's no need to address the re-rupture, just do the resection of the lateral end of the clavicle in case there's an indication for that. Arthritis, you can have glenohumeral arthritis and effusion along with a re-tear. Now, is it obvious you should go for the re-tear? Maybe not. You can do injections, you can do debridement, or even go for a total shoulder. You never know. Other kinds of degenerative changes, just take a look at that spur over there, that lateral acromion spur, and you can check there's this partial minor re-tear. Should you address the re-tear? Maybe not. Maybe some minor decompression can solve the problem. Then biceps pathology. We all know that that's a very common cause of unsuccessful cuff repairs. Not necessarily failures of the construct itself, but it's a reason for failures. So make sure that you check on partial tears of the subscap, check how the long biceps is, if it's unstable, synovitic, and probably everything you need to know is to address it and not necessarily address the re-tear. The osacromial, well, that's rare. We all know that we shouldn't really do anything to that. But in case you see on an MRI some bony edema, if it's mobile, if you really have the notion that it's painful, well, at least consider, do not forget that it's there and it's painful before deciding what to do. Suprascap nerve lesions, they're not uncommon, as you know. So when you have this wearing off, this atrophy of the scapular muscle belly, if you see on the MRI differences in the looks of the signal of the infraspinatus and teres minors, you should address this either by decompression of any eventual cyst that's there compressing the nerve, or even decompressing the nerve itself. Scapulothoracic dysfunction, dyskinesia, asymmetry of the scapula, that can come along with improper rehab or scoliosis. So always look for this and rule out these situations, because this can be the cause and no need for repair of the cuff tear. Cervical spine pathology, that's quite obvious. If you have a C5, C6, you can have impairment of the function and strength of your shoulder, and you should be aware that even if you repair that situation, you will have issues in the rehabilitation, because probably the hernia can be, or the radiculopathy may be the issue that needs to be addressed. Now, this is another case. It's a clinical case which I find quite interesting. This is someone that back in 2015 had a cuff repair, studied by an arthroscopic approach, then converted to open. 2 years later, because he kept on with some pain, he had an MRI done. The cuff seemed globally okay, and the surgeon decided to do a proximal tenodesis because he found, or he thought that a slap lesion or a biceps pathology was the case. for the situation. And then I saw this patient last summer, and this was the first X-ray that was done in all these years, and it turned obvious that there was this major osteophyte in the lateral acromion due to a failure of the deltoid. So be aware that this is another cause of failure that can bump into you, especially after an open approach, regardless of having a re-rupture of the supraspinatus, for instance. And in these cases, obviously, the approach would have to be taking out that bony spur and reinserting the deltoid. So as final messages, there are no actual guidelines for appropriate management of these failed cuff repairs. The evidences we have are not of a very high quality. Still, they exist and they're useful. And decisions definitely depend a lot on personal experience and from extrapolated scientific data available in the literature. And of course, you have to be aware of associated conditions. So doing the repair again, be aware that the pre-op range of motion is a very important factor for the prognosis of that situation, and you should revise in younger patients, no pseudoparalysis with a deltoid that's intact, and of course if you have a repairable lesion. Thank you.